have to move on. The next speaker is Stuart Shapira, who will speak about routine second testing in newborn screening for hypothyroidism and congenital adrenal hyperplasia. Is one screening test sufficient?
Well, thank you very much. For my disclosure this morning, I'm obliged to state that for my vocation, I am a clinical geneticist and a metabolic specialist, but for my avocation, I am a certified group exercise instructor. And in fact, at this time of the morning, on Saturday morning, I'm generally teaching a step aerobics class. So I must forewarn you that if I see anyone who's glazing over during my presentation or falling asleep, I will be obliged to slip into my other role and get everyone up and exercising, so be forewarned. So let's get started. So when newborn screening began in the 1960s, specimens were typically obtained at 48 to 96 hours after birth. And the reason for waiting this period of time to obtain the specimens was to decrease the proportion of false negative results, so as not to miss cases of metabolic disorders because the infants didn't have adequate nutritional intake, or because there was a delay in the rise, the elevation of TSH, thyroid stimulating hormone, which would be indicative of primary congenital hypothyroidism. However, there have been pressures to decrease healthcare costs, and this is manifested in early discharge of mothers and newborns before 48 hours of life. And although the American Academy of Pediatrics and others have addressed this issue, early hospital discharges still continue to occur frequently, and this has impacted newborn screening. So in response to early discharge, it turns out that 9 states have mandated that a second newborn screening test occur on all newborns, regardless of what the first screening test showed. And 3 states recommend that a second screen occur on newborns. And in fact, in those states, more than 85% of newborns receive a second newborn screening test. And these second screening tests are performed when the infant is 8 to 14 days of age. And by performing this second test, it's thought to reduce the chance of missing cases of clinically significant disorders. This is particularly for congenital hypothyroidism. And the infants in those states that receive this second screen account for 22.4% of all U.S. births. And the states that do those screens are shown here in mauve. Now, a number of questions have been raised about the utility of doing a routine second test. For example, is the routine second screen actually the appropriate means to detect cases that would otherwise be missed? Or are there other ways? Are laboratory-based practices in the states that do these 2 screens actually increasing the likelihood that cases aren't detected on the first screen because they know they're going to get a second crack at these infants on the second screen? And does the second screen detect treatable cases and prevent negative outcomes, or only milder conditions that would be detected later on clinically being picked up on this second screen? And finally, is this second screen a reasonable, cost-effective public policy? It's expensive to screen every single baby twice. So there have been some state-based studies that have looked at some of these questions. They've been on smaller sample sizes, and they were really limited by the processes and the procedures going on in the laboratories of single states. So to that end, the routine second testing study was born to look more globally at what's going on in this routine second screening. And the states that were invited to participate in this study were all those that are providing a routine second test on at least 85% of newborns, and they're listed here. And as well, 3 states that provide a single screening test: California, Massachusetts, and Wisconsin. This is a 5-year retrospective study between this time interval. And in this map, the states shown in green, California and Wisconsin, have already contributed their data on cases. And Massachusetts is shown hatched here because they're in the process of getting us their cases in the next month. And Oregon, Texas, Maryland, and Delaware are 2 screen states, and they have provided all of their cases, and Alabama is in fact providing us their cases over the next month. So the data elements that are being provided are demographic information, so the infant's sex and the infant's race, ethnicity, and the birth weight on the infant, and factors that could affect screening test result, such as was the infant breastfed or formula fed or on TPN, was the infant transfused prior to screening, various laboratory testing factors, the type of testing, the period of time between when the test was obtained and when the assay was actually run in the laboratory, the various cutoff values and the actual screening test results for the analytes, information about whether the infant was positive on the lab's first screen or a second or subsequent screen, or if the case wasn't detected at all by newborn screening. And then a number of clinical factors for both hypothyroidism and CAH, congenital adrenal hyperplasia. So what were the confirmatory test results? Was the infant treated? And if so, how they were treated? Is there a family history? And information, for example, on viralization in CAH cases. So individual level anonymous data were submitted to the Association of Public Health Laboratories for analysis. And let's get to the data. So this is looking at all cases of congenital hypothyroidism thus far submitted, the 1 screen states, California and Wisconsin, the 2 screen, remind you, Delaware, Maryland, and Oregon, Texas. So far, 2,559 cases have been submitted. They were diagnosed on either the first screen, the second screen in states that do 2 screens. In the 1 screen states, they do some targeted second screening, particularly in premature infants, so they may pick up a case not on their first screen, but later on. But I'm going to focus for the rest of the talk on just primary congenital hypothyroidism because both the 1 screen and the 2 screen states pick up this form of hypothyroidism. The other types are not necessarily picked up by all states. So these are the total number of cases, and I want to draw your attention to, in the 2 screen states, about 12% of primary hypothyroidism cases were not picked up on the first screen. They were picked up on the second screen. And I want to look at the differences in the cases in these states that were picked up on the first versus the second screen. So what characteristics are predictive of a case being identified in these 2 screen states on the first versus the second screen? So we looked at a number of characteristics. These were the ones that were significant. So for example, the state, and these are the odds ratios. So if the case was in Oregon or Maryland, they were less likely to be picked up on the first screen versus the second screen compared to cases in Texas. Also, black infants and Asian Pacific Islander infants less likely to be detected on the first screen compared to white infants. And then female infants were more likely to be picked up on the first screen. Infants who were extremely very low birth weight, less likely to be picked up on the first screen. If your sample was collected at more than 24 hours of life, you were more likely to be picked up on the first screen compared to infants whose samples were collected at less than 24 hours. And if it was more than 3 days from between the time from when your sample was collected to when the assay was done, you were more likely to be picked up on the first screen compared to if your sample was less than 3 days old at the time that it was assayed. So all of these significant variables were put into a predictive logistic regression model, and it turns out only one variable was predictive significantly as to whether or not you would be picked up on the first versus the second screen, and that was race ethnicity. All the other variables fell out of the model, so the best predictor was race ethnicity, where you were less likely if you were black or Asian Pacific Islander to be picked up on the first screen compared to white infants. Now turning to congenital adrenal hyperplasia, again, there were a significant number of cases that were picked up on the second screen, 40%, almost 40% of cases in the states that do 2 screens. And so the same question arises, what's predictive of whether a case will be picked up on the first versus the second screen? And it turns out that the only cases identified on the second screen were cases from Texas. The other states didn't have any second screen positive cases. And because of our agreement with the states, we're not allowed to show individual state data, so I won't show that in this presentation, but in the summary at the end, I'll show the conclusion of what was found from this analysis. But I'm going to turn back now to primary congenital hypothyroidism and look at comparisons between states that do a single screen versus those that do 2 screens. And the first striking difference was that the prevalence of primary congenital hypothyroidism was different between the two, where it was much more common in 1 screen states than in 2 screen states. And we thought, well, maybe the difference is due to differences in race ethnicity, because it's been reported previously that the prevalence or the incidence in differs by racial and ethnic groups. So we looked by the different racial ethnic groups, comparing the prevalence in 1 screen versus 2 screen states. It's borderline significant for whites, not significant at all for blacks, but Hispanics are much more likely, if they're in 1 screen states, to have been picked up with primary congenital hypothyroidism. Asian Pacific Islanders more common in 2 screen states compared to 1 screen states. So the differences are in these two, primarily these 2 ethnic groups. Now, if we compare cases on the single screen and 1 screen states, so keep in mind they do mostly a single screen, versus the first screen in 2 screen states. So if states only did a single screen, both 1 screen and the 2 screen states, what are the differerences and characteristics between those cases? There were a few characteristics that were significant. One was feeding, so infants who were breastfeeding or formula feeding were more likely picked up in states that do a single screen compared to 2 screen, formula feeding only less likely. Birth weight less than 1,000 grams, less likely to be picked up in 1 screen compared to 2 screen states. Transfused prior to screening, less likely. But then age at collection, if it was less than 24 hours of age, they were more likely picked up in 1 screen compared to 2 screen states. And also if this time to assay was shorter. Now, for congenital adrenal hyperplasia, if you look at the distribution of the types of CAH from the salt wasting, simple virilizing, and non-classical, the proportions are different between 1 screen and 2 screen states, but if you look at the incidence, it turns out the incidence of salt wasting CAH is the same. It's the incidence of the other forms that are different. So simple virilizing is more common in 2 screen states, or more commonly identified, as is the non-classical CAH, much more commonly identified in the 2 screen states. And if you compare the cases identified on the first screen in 1 screen states versus, well, the only screen in 1 screen states versus the first screen in 2 screen states, the only differences are related to the age at collection and the time from collection to assay. That this is more likely less than 48 hours of age when the sample's collected, and the assay done at less than 5 days of age are more likely in 1 screen than in 2 screen states. So in summary, there are numerous characteristics that distinguish cases detected on the first versus the second screen in 2 screen states, the states that do 2 screens. And the most significant predictor, in fact, the only significant predictor after predictive modeling for primary congenital hypothyroidism was race ethnicity, where Black and Asian Pacific Islander infants were more likely detected on the second screen. And for congenital adrenal hyperplasia, we could only look at Texas, and it turns out the only significant predictor was the type of CAH. Everything else was not significant. So classical simple virilizing and non-classical cases were more likely detected on the second screen. And when you compare the single screen and first screen, 1 screen states versus the first screen in 2 screen states, there were a number of factors that were significant for primary hypothyroidism, the main one being race ethnicity, and a few factors related to timing of collection of an assay for congenital adrenal hyperplasia. So there are, unfortunately, a number of limitations for this study. The main one is that it was a retrospective study. So the data were incomplete for certain variables. The state labs could only report the data that they had on hand. And the final diagnosis, particularly for hypothyroidism, wasn't necessarily determined after a reasonable period of time. So there could have been transient cases of hypothyroidism mixed in with the permanent cases. There were different screening algorithms between the 1 screen and the 2 screen states, and that limits the ability to make conclusions about detection of other types of hypothyroidism cases like secondary hypothyroidism and TBG deficiency. And the results are biased by the states that contributed the largest number of cases, so California for 1 screen and Texas for 2 screen states. But the strengths, this is the only comparative study between 1 screen and 2 screen states that's ever been done. It's a much larger sample size than any previous study, over 2,500 hypothyroidism, over 350 CAH cases so far, and we're still waiting for the Massachusetts and the Alabama cases to add to that. And this is from over 4.5 million births. There are numerous laboratory and medical variables available for analysis. I've only shown you a few. And the analysis of individual level data improves the ability to tease out associations. So these are the individuals involved with the study development and data analysis from the CDC, from the Wisconsin State Laboratory of Hygiene, and from APHL. These are the individuals at all the state labs who've been involved in getting the cases together. And Brad Therrell from the NNSGRC was involved early on in this project. And I want to thank you very much.